Hello, welcome back. Happy New Year, 2022. This is Adam Rosen. You're listening to the Total Knee Tips and Pearls podcast. So, full disclosure, because I don't want to mislead you by the title talking about robotics, that I'm going to give you all these little details, tips, and pearls on how to do robotic surgery, because we haven't got it in our hospital. So, a little bit of this is me venting, but I've had a lot of experience in the cadaver lab, and I've done a lot of work on the back end attempting to get it in. So I know a bunch about it, and I just want to share some insights because I believe robotics are here to stay, but I don't want young surgeons to have a misunderstanding of the importance of robotics or the importance of not knowing how to do a manual total knee. And I think a lot of this comes back to when I started doing navigation, back in 05, 06, that, I did a lot of navigation in the beginning, and I learned a lot by doing it. I learned, a lot of real-time information and data, my tendencies, and I was able to use what I was seeing on the screen, I believe, to help make me a better surgeon. But it is interesting because when you talk about robotics, 6 years ago, when Stryker purchased Mako, I was really interested in getting Mako in. And for, the obvious reasons. One, it was cool. It's interesting. It's a robot. Two, it's publicity. It's advertising. It brings patients in the door. And I think that is a big portion and component. When you talk to people, I think it's almost like the anterior-posterior battle in the hips, right? You get the anterior surgeons that do it and love it, and they swear by it, and they try to, convert every posterior surgeon over to the anterior. And you can find a study that shows that it's better, and you can find a study that shows that it's not, and you can find a study that shows that this complication is higher. So the biggest thing is whatever you do and however you do it well. So if you do anterior, do it well. If you do posterior, do it well. But don't switch just because until someone proves that it is 100% better, it is just a different way of doing things. And that's sort of the same thing with robots. You can find a study that shows this robotic surgery outcomes are better, and this one the same, and this one is not better. So you can find all of that information. The thing that I've always thought would be interesting with robotics, which hasn't really come to play yet, and you may have heard me talk about it a little bit before, is that the data that's collected with robotics is so much as far as information. And if we can collect the preoperative data and the intraoperative data, and then the postoperative data, the patient-reported outcomes, and then funnel that into some type of deep mind thinking, augmented or artificial intelligence, this, I believe, at some point, hopefully in the near future, if someone takes the time and the effort and spends the money to do this, is we will know, and this is where I think robotic surgery, whether or not the robot cuts the knee or you do it with your hand, but some type of augmented reality or robotic surgery will allow you to know, do I cut this femur in 3 degrees, 4 degrees, 5 degrees, 6 degrees of varus, or valgus, 7 degrees of valgus? Do I cut the tibia at 0? Do I cut it in a degree of varus? Do I cut it in a degree of valgus? And knowing that information will be key. I always say it's sort of like a chess system that if you play chess at all, if you go online and use the chess engine, if there's a move that's played, it will tell you, what the best next move is. And if you make a move, it'll let you know that was a blunder. And this is the same thing I think that robotic surgery can offer us in the future, whether or not, again, you're doing it with augmented reality and you're seeing it and you're just making the cut because it's telling you that you have to be at 4.5 degrees of valgus, not 5, or you want to cut it 1.25 degrees of varus, and you can dial that in on a jig, or you can use the saw to cut it for you with the robotic arm. But it's going to let you know that based on the patient's height, weight, range of motion, deformity, anatomy, it's going to let you know that based on looking at thousands of other knees and the patient-reported outcomes, that patients like this do better if you cut it like this. And they also do better if you balance it like this. It's one of the things I teach is that, if you have a really tight knee, tight jointed person, the other knee's tight, their elbows are tight, Their shoulders are tight, their hips are tight. If you leave that knee loose, more often than not, I find those patients don't like it. It feels unstable, it feels loose, they have swelling. Whereas if you take a little old lady who's a little loosey-goosey and you tighten her up and you put her collaterals on a lot of tension, she hates it. It's painful, it's sore, it pulls. So that is the art of medicine. It's the art of surgery. And again, if you funnel everybody into this mechanical alignment philosophy and you cut every knee at 5 degrees of valgus and every tibia at 90, if you do the same philosophical thought process with a robot and you don't really think about each individual patient, I'm not sure that you're going to get better outcomes. But I do think it's important because if you're in training, if you're a resident or you're a fellow, I do believe that you should have access to robots, whether or not it's Mako, whether or not it's Rosa, whether or not it's Velys. And I think it's useful. I haven't spent any time with Velys, but I spent a little bit of time with Rosa and a little bit more time with Mako. So I have some understanding of the workflow and the system. And they're very interesting. I really like the idea. So for me, I can do a lot of stuff with my hand and I may fiddle and, it's just based on a look or a feel. I add a half a degree here, a millimeter here. Sometimes it's hard to teach that. With a saw and with a robot and a screen, I think in a teaching setting, if someone says, cut 1 more degree of slope, you can really see what slope you cut, what you were aiming for, and what you cut after you recut, or what the arm gave you and what it looks like in balances. And if you're tight and you modify things and add a little bit more slope, what that does. And you can also see balancing in the sense of, I'm sure many of you have had the experience where you've picked up a knee and you thought, oh, it feels pretty good. And then your attending picks it up. I don't like it. I'm going to do X, Y, Z, modify this, release here, cut there. And you go, oh, so you feel that it's better. But the hard part is, why didn't you feel that it wasn't good when you first picked it up? It felt good to you initially, but it feels better. So you can recognize that it's better now. And by looking at a screen, I think a lot of people will be able to see those numbers and have an assessment of, oh, that's what a millimeter feels like. Oh, this is why it's looser on the medial side and tighter on the lateral side. Ah, okay, I see it and I feel it. And you can put a number to it, and hopefully that may ingrain that information in your head versus just saying, yeah, don't you feel it? You can't see it because there's no quantifiable data also it's in front of you. And also, if you're trained in these, when you come out and get a job, I guarantee that if you're a good candidate and the person next to you is a good candidate and you have zero robotic training and they have robotic training and fellowship, they're more likely to get the job. So that's the other reason I think, many places like us, part of our mantra is research and education, and I think robotics does both of those. It allows for research and it educates. But a lot of, healthcare systems are looking at the financial cost, and you get into the point where, okay, you prove to me that our patients, will have better outcomes. Well, it's hard to prove that, right? At this point in time. And it's, really hard to show, 5, 10, 15-year data with robotics that are not out for that long. And you don't have, long prospective randomized studies to prove that with statistical significance at this point. At that duration, you can show early term results. And the question is then, does it bring in more patients? And it's interesting because the companies all sell it in different ways, right? They'll say, oh, it's you need it for marketing, and the hospital down the street just bought 2, so you need some, or you're going to lose market share. Well, if you're busy, there may not be any room for additional business. So some people, in hospitals look at it and go, well, why do we need it? We're already full. So we don't need to bring in more patients, and we're not afraid to lose it to the hospital down the street. Other places will say, oh, to make you more accurate. Well, I always ask, if you're not accurate, why aren't you accurate? And you better find ways to fix that. And then the other thing becomes, marketability. I find many patients, come in asking for robotics. It's a lot easier to go, yeah, sure. Yeah, we have robots. Sure, we'll do a robotic knee for you. It's a lot harder and longer of a discussion to explain to patients why you don't have it and why you don't feel it's necessary for their knee and why you still believe that they're going to have a good outcome. It's a longer discussion. And some patients, they don't care. Some patients aren't interested, don't even know about it. But I do think it's important to know it. But I also think it's important for you to know how to do it without a robot. And that's my fear going forward, is that you're seeing, a lot of people come out of training, they've done a ton of IMHSs for intertrachs, and they haven't done a DHS. DHS is bread and butter orthopedics. So if you have a stable intertroch with arthritis, most joint surgeons are like, don't put an IMHS in because now I got to convert it. You buggered up the abductors. It takes forever to get the nail out, longer blood loss, longer surgery. Put a DHS in. I can take it out in 6 months and convert them to a hip replacement once the fracture's healed. And that's my fear, though, with robotics. I think some places you might see so many robotic surgeries that you don't get the reps on the manual surgeries. And why is that an issue? Well, you can look at a screen, but if you're fixated on the screen and you're fixated on the numbers and you're fixated on the robot and you're fixated on the arm, you may miss the whole picture in front of you. You may miss looking at the anatomy. You may miss looking at how the knee feels in your hands. And you're going to miss out on some of that art of the training of surgery. And then at some point, the robot's going to break down. It's going to shut down. A tracker's going to come loose. Some mechanical issue, electronical issue is going to happen. Or the patient didn't get the CAT scan and they got moved up, or the robot's in the other room and your partner was using. So something is going to happen where you need to do manual knees. So you still need to know how to do a manual knee. And you have to know how to do a manual knee well. And I think it's important to know how to do a manual knee well and then add in robotics. And then I bet you when you go back to doing manual knees, you'll be even better at doing manual knees. But then you can pick and choose when you do robots. And if you want to do a robot all the time, great. And those few times where the robot breaks down, you know exactly how to do the manual knee. And if something looks off, we always said, even with navigation, garbage in, garbage out. So if something's off with the CAT scan, if something's off with the tracker, and, the computer screen's giving you something, and maybe you cut it and it just doesn't look right, you can't believe that it's okay to leave it that way. It doesn't really feel right. It looks like they're in varus. It looks like they're in valgus. But the screen looks okay. It's telling me that I'm straight, telling me my mechanical alignment's perfect. You got to know when the data that you're seeing on the screen is not correct, because you don't want to leave the operating room. And I think if you don't have enough of the manual knee training, you may miss out on seeing or observing those nuances and knowing when not to trust the computer and knowing when to bail and go back to a manual instrument. So for me, honestly, I hope in the near future that our hospital brings in one or more of the robots. I do think it would be an interesting tool for me because I do like to tinker and I'm really interested in all those numbers. Again, like you may have heard me talk about in the other thing, I'm definitely more interested at this point in augmented reality. I like using the saw in my hands. It doesn't tire me out. I like to kind of, make subtle modifications. It's sort of my artful way of doing knees. And, I try to match people's anatomy. It's sort of like a blend between, manual and kinematic and measured resection sort of all in one. You can do that with a robot. But for me, being able to visualize it, dial it in on a jig, cut it, see it, and then kind of fine tune it at the end. I do believe that might be the way to go in the future, especially as more and more surgeries go to outpatient centers. It's so much easier to grab your goggles, put them in a little, briefcase, take one little set over the surgery center and sterilize it, as opposed to like, how are you going to bring the whole robot from here to there? Like you can't put it in, in your backpack and carry it across the street from the hospital to the surgery center. So, as far as moving it from room to room, OR to OR, location to location, augmented reality is a whole lot better. But I do believe in the next 2, 3, 4 years, I think you're going to see the data that you get with augmented reality catch up to what you get with a lot of the modern day robots. But what I really, really hope to see, so all of you young surgeons that are listening, is really, really try to work on getting that preoperative data, intraoperative data, and patient-reported outcomes. And that's going to be the interesting thing in 2, 3, 4 years once you get tens of thousands of knees, is to go back and reassess that information and figure out, okay, all the patients that were happy, this is what we saw pre-op and intra-op. And all the patients that were not happy, this is what we saw pre-op and intra-op. So the computer can then start to not just give you numbers and degrees, but actually start to predict for a particular patient based on their anatomy and based on their deformity and based on the disease pattern as to what the best numbers are that we should be aiming for as far as rotation, alignment, balancing, sizing, all of those different things. And I think once we can figure that out, you're going to take that 20% dissatisfaction rate And I would say best case scenario, if we can get that down to 5% dissatisfaction rate, I mean, that would be a home run. I'm not sure you're ever going to get 100, but if you could get 95% of people having total knees to be extremely happy with the outcome, I think that's a home run. And anything better than that, you're a genius. That you should win the Kappa Delta Award, our sort of Nobel Prize of orthopedics, because if you can get us into that 98, 99%, there's something that you figured out that the rest of us couldn't. So just my 2 cents. Hopefully in the next year or so, I can get back to you with robots and my little tips and pearls on how I do robotic surgery, or possibly, hopefully, how I do augmented reality surgery. But in the meantime, sticking with my my manual stuff, and I will keep feeding you information that hopefully will help you, help your patients, and help you become a better surgeon. Until next time, I'm Adam Rosen. Thanks for listening. You've been tuning in to the Total Knee Tips and Pearls podcast. You've been listening to the Total Knee Tips and Pearls podcast. Make sure that you're subscribed so you'll be notified of future episodes. And please take the time to leave a review. It helps other people like you find the show. Until next time, stay safe.